Evening and welcome to the Network for Responsible Public Policy. I'm Jenny Wilson, a trustee of NFRPP. On behalf of Rhoda Shermer and the Board of Trustees of NFRPP, we're so happy that you've joined us tonight. If you've been with us before, you know that the Network for Responsible Public Policy connects people with thought leaders who educate and inspire. If you're new to NFRPP, please visit our website, nfrpp.org, to learn more about our program and our commitment to bringing you credible information from trusted sources. Tonight, we'll delve into the state of healthcare in America. We're so fortunate to have with us two distinguished healthcare thought leaders. Dr. Jonathan Gruber is the Ford Professor of Economics and the Chairman of the Economics Department at the Massachusetts Institute of Technology, where he has taught since 1992. He's also the former Director of the Healthcare Program at the National Bureau of Economic Research and the former President of the American Society of Health Economists. Tonight, Jonathan will be joined by Joel Cantor. Joel is a distinguished professor of public policy and the founding director of the Center for State Health Policy at Rutgers University in New Brunswick, New Jersey. Both Jonathan and Joel's detailed bios can be found on the NFRPP website. As always, tonight's conversation will generate questions, which we welcome. Please type your questions into the Q&A box. Our panel will respond to as many as possible. Jonathan and Joel, I'll turn it over to you. Thank you.
Thank you. Well, I think that we'll start. I'll start with a few comments. Thank you, Jenny, for that introduction. I'm going to start with a few comments to set the stage, but I'm mostly here to hear your questions. I think that the main thing to understand about healthcare is there are very few questions to which there are truly right answers. It's a complicated and subtle topic, and it's important as a result that we keep our mind open and discuss all aspects of the problem. And the important thing to start with, for my talk tonight, is to recognize that one type of black and white thinking we want to avoid is the notion that I often get of, have we fixed healthcare? Is healthcare reform over? These are questions that are not well posed, because when you have a sector that's 18% of the economy, you never fix it. The issues never end. You constantly want to reinvestigate and think about how we treat healthcare in America, because it's going to be a constant issue for the rest of our lifetimes and the lifetimes of our children and grandchildren. And so the best way to think about it, as with any issue that's dynamic and ongoing, is to understand how we got to where we got to think about where we are, and to then reflect on where we need to go. I'm going to try to do all that in about 10 minutes. So let me start with how we got to where we got to. Let's try to cast our minds back to the year 2008, 2009. Let's see what healthcare was like in America at that point. In America at that point, most Americans then, as in today, got health insurance from their employer. It was good health insurance. People had dissatisfaction, and by and large, it was pretty good health insurance. That was about 60% of people. About 20% of people got health insurance from the government, either through the Medicare program, if they were elderly, or the Medicaid program, if they were low income. And the other 20% of Americans were, quite frankly, screwed. They had to find themselves in what we call the non-group insurance market, a market where insurers were free to discriminate against the sick, to deny you insurance coverage because you'd been sick, to charge you a higher price because you're a woman, or to exclude coverage for things like cancer if you've had cancer. As a result, most of the 20% was uninsured. To deal with that, we first, in the state of Massachusetts, under Governor Romney, and then at the federal level under President Obama, passed fundamental healthcare reform at the federal level in the form of the Affordable Care Act that tried to resolve this issue through what I like to think of as a three-legged stool. I actually wrote a comic book. It's technically a graphic novel, but it's really a comic book to try to explain healthcare reform. It's ambitiously entitled Healthcare Reform. You get it for about $9 on Amazon. And in that, because I like to take graphic images. And the image I think of as a three-legged stool. The first leg of the stool was let's stop insurers from being able to discriminate against the sick. The second leg of the stool was, well, if we're going to tell insurers they can't discriminate against the sick, we've got to make sure everyone buys health insurance. So let's have an individual mandate so that people have to buy health insurance. And the third leg of the stool was, well, gee, if we're going to mandate people to buy health insurance, we got to make sure they can afford it. So the third leg of the stool was subsidies to make health insurance affordable. And that was the fundamental core of what we did in Massachusetts, and then with some changes we did at the federal level. Well, what were the effects? Well, the immediate effects were quite good from a policy sense. First of all, and most importantly, if you take one thing about the Affordable Care Act away from my talk, it is this. We are no longer the only developed nation in the world where you can be denied insurance just because you're sick, or thrown off insurance just because you're sick. This was a stain on our record as a social democracy, that we did not have guaranteed health care for those who needed it. We now do. Insurers can no longer discriminate against you. People are no longer one bad gene or one bad traffic accident away from bankruptcy. That's a fundamental accomplishment. We also covered about 20 million people with health insurance. And so those are great accomplishments. The problem was the law was not popular for various reasons we get into. Most people did not approve the Affordable Care Act. And as a result, there was sort of a sense in 2017 it might get repealed. As you remember, it came very close. But then a funny thing happened. People started appreciating what the Affordable Care Act was giving them, and it survived. And today, the Affordable Care Act is stronger than ever. It's probably covering about 24 million people who'd otherwise be uninsured. And it's doing so with record enrollment in the state health insurance exchanges. So what we've got today, if you go back to where things were in 2008, where are we today? Well, it's still true most Americans get health insurance through their employer. A larger share get health insurance through public insurance. There's been a large expansion in the Medicaid program through the Affordable Care Act. And a much larger share now buy health insurance on their own. Whereas before that was a very weak discriminatory market. Now, more than 20 million people buy health insurance through the healthcare exchanges that were set up by the Affordable Care Act. So we're in pretty good shape in the sense that we've dramatically improved health insurance coverage, but problems remain. And these are the challenges going forward. There's a number of problems that remain. The first problem is we still have about 30 million uninsured Americans, 25 to 30, the number's dynamic. We have a lot of uninsured Americans. Who are they? Well, first of all, probably a third of them are undocumented immigrants who did not qualify for the Affordable Care Act and do not qualify for health insurance coverage in almost all situations. The rest are largely people who just simply don't want to pay the cost. They think it's not worth it. They may be right. They may be right that for them, having health insurance isn't worth it. For others, they may not be thinking about it properly. But probably the other really large group is people who are eligible for basically free health insurance and don't take it. There's a lot of Americans who could get very free or very cheap health insurance, and for some reason aren't taking it. It could be they're not aware of their entitlement. It could be language barriers. It could just be they feel like they don't need it. Even though it's free, they don't want it. So I think the next step in trying to really expand coverage is to help the tens of millions of Americans who are actually eligible for free or very cheap health insurance to understand that and to take advantage of that entitlement. So that's one problem we face. Another problem we face is that even those with health insurance often have quite high healthcare costs. There's been a rapid growth in deductibles and more generally in the amount people have to pay when they get medical care. This is a problem that has grown rapidly in the last several decades. And really, in some sense, we know the answer to this, and that's the answer in the Affordable Care Act, which is that we should have what people pay be related to what they can afford. In the Affordable Care Act, we have what we call income-based cost sharing. If you're poor, care is largely free. If you can afford it, then you can face a sizable deductible. That's the way it should be. The amount you should have to pay for health care should be related to the underlying resources that you have to pay for it. So that's something we could try to extend and help the millions of people who don't benefit from income-based cost sharing. But this is all really only one side of the coin. The other side of the coin is the ongoing and dramatic rise in healthcare spending. In 1950, healthcare costs in the US were about 4% of the total economy. Today, they're more than 4 times as much at 18% of the total economy, and they continue to grow rapidly. Now, the good news is actually over the last about 15 years, roughly since the passage of the Affordable Care Act, healthcare costs have grown at a historically slow rate. Now, is the Affordable Care Act responsible for that? We'll never really know. I think it probably is partly, but probably not the majority. Really, we've just seen a transformation in the way healthcare is delivered that's really slowed the growth. So we've got a reprieve, but I think many of us feel it's just temporary. That's only a matter of time till healthcare costs start growing rapidly again. And we need to think about what we're going to do about that. And we think about it, people naturally look to other countries. They say, well, gee, healthcare costs a lot cheaper in Europe. What do they do? And we've thought about that a long time. And really, I would say the health economics profession, maybe Joel's a different view, but I would say my view is the health economics profession has come to a pretty solid consensus, which was really best summarized by the health economist Uwe Reinhardt about 25 years ago in an article entitled, "It's the Price is Stupid." Because basically, we pay more for healthcare because we pay higher prices for healthcare. You know, I teach basic intro economics here at MIT. And the basic principle of basic economics is respect the market except where it doesn't work. Respect the market except where there's what we call market failures. And there's no place the market works worse than healthcare. Every market failure economists have ever invented exists in healthcare. And we've known this since the famous economist Kenneth Arrow pointed out in 1963. As a result, every other developed country in the world does not let the free market set the prices they pay for healthcare. The government regulates or negotiates those prices. We are the only country in the world where that's not true. And guess what? We pay the most in the world. We pay twice the average cost of Europe for a hip fracture, for fixing for hip replacement. We pay 3 times as much for many brand name drugs because the rest of the world regulates the prices. We don't. So in theory, the answer is simple. We should just regulate price like the rest of the world does. In practice, this faces 3 complications that we need to deal with going forward. The first complication, and probably the most important, is political. As Uwe Reinhardt also said, healthcare prices equal healthcare income. If we regulate healthcare prices, then some people may see their income fall. Now, here's the good news on that one. The good news on that one is no one has to see their income fall. You know why? Because we can actually afford 18% of GDP on healthcare. We just can't afford the 40% of GDP it's projected to get to. So everyone can keep their income. Those orthopedists make $800,000 a year. Great. They can keep making $800,000. It can even grow. It just can't grow that fast. We don't have to lower the level of healthcare spending in the US. We just have to slow the growth, which, as I said, has been slowed for the past 15 years. But I'm very worried that that's going to pick up again, and we need a cap on that. That's not going to be easy to do politically, and that's, to my mind, the most fundamental, a really fundamental challenge. The second challenge, I think, is less fundamental, and it's really sort of a cover for those who don't want to regulate prices, which is that, well, gee, if we regulate prices, we'll get less innovation. That, gee, if we don't let these drug companies and other healthcare providers earn a lot of extra profit, they won't innovate and think of cool new things to do. Let's be clear. Innovation in the US healthcare sector has been unbelievable. Okay? Yes, it's true. We spend 4 times as much in healthcare as we did in 1950. But guess what? Healthcare sucked in 1950. I mean, if you had a heart attack, you are 4 times as likely to die in the first year. Infants who are born low birth weight are 5 times as likely to die in the first year. Our healthcare is much more expensive, but it's also much, much better. And that's partly because of all the innovation that's happened. Here's the good news. A lot of that innovation happens not just with the private sector, but with the public sector as well. This is the highlight of a book I've written called Jumpstarting America with Simon Johnson, where we highlight that what made America great, to coin a term, was the government investments in R&D in the period after World War II. That's what gave rise to everything from the GPS to modern pharmaceuticals was based on government-funded science. If we starve, the government is the largest payer for healthcare in America. If we let healthcare prices grow unfettered and starve the government, we won't get the spending on government innovation that really drives economic growth. So the answer is we can have our cake and eat it too. The private sector can make a healthy profit. But if we limit that profit and redirect some of that money to government innovation, we can grow even faster as a country. That's the argument we make in our book, Jumpstarting America. And then finally, I have the last problem, and the one I've been focused on lately, which is when we think about regulating healthcare prices, the way the rest of the world does it is they say, look, what's something worth? They say basically, how much is something worth in terms of how much it improves your health? And then they will let you charge that much. And that price is typically well below what you pay in the US, but not always. And in particular, not for the coming tsunami that's coming for all of us, which is cellular and genetic treatments for disease. These are miraculous cures for diseases we never thought we could treat. Unbelievably miraculous at millions of dollars a shot. Guess what? They're worth it. Spending millions of dollars to save a life. There's a disease called spinal muscular atrophy. Horrible disease. Kids are sick and dead by age 2. I mean, you can't imagine anything worse. They've cured it. And they want $2.1 million for the drug. Guess what? That's worth it. If we can save a baby's life for $2.1 million, that is absolutely worth doing. Okay? The problem is, what happens when they invent a drug like that? And we can afford a society because there's only a few thousand babies born each year with this disease, or a few hundred. What happens when they have this disease for heart diseases and cancer, where millions of people have them, and they want $1 million a pop? It'll still be worth it, but then we won't be able to afford it. And that's the next frontier in trying to think about how we're going to deal with healthcare costs, is not just how do we regulate things we're paying too much. How do we regulate things we're paying the right amount? It just adds up to too much. And that, I think, is a major issue going forward, which involves not only health economics, but ethics. And thinking about how, as we society, do want to think about these miraculous treatments that are miraculously expensive. And I think that's the other big issue we have to think about going forward. So bottom line is, when you think about health issues in the US, you want to think about coverage, and here we've made a lot of progress. The Affordable Care Act was a huge success. Now I'm biased. I helped develop it, but I will not, every fact I'll use in this call is citable, and you can go look it up. I think along almost every metric, it's been a huge success. But the next frontier is healthcare costs, where we've got a big battle ahead of us, and one the next generations will be fighting. So I will stop there with that very quick overview. I'm happy to keep talking, but I'd rather answer your questions. So I'll turn it over to Joel.
Fabulous. Thanks so much. You anticipated and answered most of my questions. And we're starting to get a few questions in the Q&A. So for those of you who are on the webinar, I encourage you to use the Q&A button, put your questions in. I'll bring them into the conversation as we go. But let me stick with one of the sort of three big issues that you raised at the end, and that's price. So let's unpack that a bit. So we hear about forces in healthcare systems getting bigger and bigger. Those big health systems argue, well, they can invest more in quality, they can improve care, they can become more efficient, they can lower costs. At the same time, we see private equity investment in certain healthcare services that's pumping in a lot of money. Maybe that can improve quality as well. So could you opine a bit on what the sort of the forces underlying our price problem? What's driving the price problem?
And Joel, it's a great question. So to understand, let's think about a place where price isn't a problem. Let's think about apples. So why do we think the price of apples isn't a problem? Well, for a couple reasons. First of all, because you kind of know what an apple's worth. You shop for apples your whole life. You kind of know what an apple should cost. Second, if a place tries to charge you too much for an apple, you go next door and get the apple at a different place. Okay. Third of all, apples are kind of all the same. That's not true with healthcare. First of all, you don't know what healthcare should cost. I have no idea what a back surgery should cost or a knee replacement should cost. I've never done it. Maybe I'll do it once in my life. Second of all, there's not competition. Okay, if you have a heart attack on Nantucket, there's one hospital to go to. And it's not just geographic limitation. So when our beloved Big Papi here in Boston, which had a gunshot in the Dominican Republic, did he return to Boston and go to one of the top-rated hospitals in the world, which is actually the official hospital of the Red Sox, Beth Israel? No. He went to one that's slightly higher rated, Mass General Hospital, which charges about 50% more and isn't quite frankly that much better, but everyone thinks it is. So he went there. So it's not just that people only have one hospital to go to, there's only one hospital they want to go to. Third of all, healthcare is dramatically different. It's not like apples, and it's hard to shop. It's hard to compare. So for all those reasons, healthcare markets don't work. Now, when a market doesn't work, when you don't have competition, we have incomplete information, that's when providers, not because they're evil, just because they're profit maximizers, will charge high prices and they'll make excess profits. One example of that, Joel brought up, which is the ongoing consolidation of our healthcare sector. There's been a shrinkage in the number of independent doctors, independent hospitals. When that happens, they argue, look, this is great. So for example, 2 hospitals in the Boston area merged. They would look, we've got all this excess capacity, it's wasted. Let us merge. We will work together to more efficiently deliver healthcare. What happened? They merged. They left all the excess capacity. They just raised prices. So the answer is yes, in principle, these mergers could deliver cost savings. In practice, they don't. They've been now studied extensively, and healthcare mergers raise the prices to consumers. Sometimes they lower costs, sometimes they don't, but they always raise prices to consumers. Okay, so that's an example where the market is not working and the government needs to step in. It could do through stricter antitrust regulation, but there's a recent study shows that of the thousands of hospital mergers, of healthcare mergers that happen each year, about 20 or 30 are subject to antitrust regulation. It's just not a tool that's working. We need to bring other tools to bear.
Great, thank you. So we're getting some good questions in the chat. Let me start with one. And it's about what I call administrative friction. So we have this incredibly complicated system of billing and payments, and you can have a simple procedure at the hospital and get bills upon bills for months and months. Can't it be simplified? And I'll add a friendly amendment to the question. Is this one of our big cost drivers, this sort of complex administrative system?
You know, it can be simplified. And actually, this is an important argument. An advantage of regulating pricing is that it would also eliminate a lot of the middlemen that complicate our healthcare system. Basically, what you have these very powerful providers that have a lot of market power and insurers who don't want to pay what the providers want to charge. So as a result, middlemen emerge. Things like pharmaceutical benefit managers on the pharmacy side or group purchasing organizations on the hospital side to try to negotiate between these two. Well, guess what? They got to make money too, and they're going to add paperwork too. If we simply set the price at the government level, those middlemen will go out of business. That would be great. That'd be less cost in the healthcare system and less administrative hassle in the healthcare system. Now, let me be clear. It is not easy to regulate prices. I'm being very glib about this. Okay. It's not easy politically. It's not easy administratively. It's a challenge, but the administrative cost burden would certainly go down if we went to more control over how healthcare prices are set.
Great, thanks. Let's switch to Medicare for a minute. I just have a suspicion that many of us on the call are personally interested in Medicare. So a two-part question. One is, what about its viability? We keep hearing about trust fund being depleted and are people who turn 65 10 years from now out of luck? And a related question is, and you mentioned prescription drug prices on the one hand. Could you elaborate a bit on how, Medicare is one of the biggest payers in the system, how it could use its leverage to help address the cost problem? So yes. Viability and leverage.
Yeah, great. Yeah. Great. Both great questions. On the viability, so part of Medicare is very complicated. We don't need to get into details, but part of Medicare is run out of what's called the trust fund. And that trust fund is set to expire by current estimates in about 13 years. What does that mean? That means technically in 13 years, Medicare will not collect enough in taxes to pay its bills. Does that mean Medicare will go bankrupt? No way. Not as long as people over 65 have the vote. I mean, you talk about a concentrated voting bloc. This will be the #1 voting issue for a huge share of the U.S. population. Medicare is not going anywhere. Okay, no way. Okay, now changes will have to be made, and those ultimately that is going to have to involve changing one of several things. Either taxes are going to have to go up. The Medicare Trust Fund is funded by a payroll tax that's currently 2.45%. That could go up. We could make people on Medicare pay more. Right now, they pay a certain amount, could make them pay more, or we could pay the providers on Medicare less. Over the last several decades, whenever we've wanted to control Medicare costs, we've gone on the latter option, paying providers less, because Medicare is a sector where prices are regulated. So we've squeezed providers. It's not clear how much more juice you can get out of that lemon. And if we really want to control Medicare, make Medicare viable, we're gonna have to come up with something else. But we'll figure it out. There's no way we're going to go against the entire block of 65 plus voters. Okay. Now, the second issue is, what about prescription drugs and Medicare? Now, once again, recall the history. When Medicare was set up, it did not cover prescription drugs, because back then prescription drugs weren't a big deal. The only drugs that were expensive you got in the hospital. In 2003, we passed what's called the Medicare Part D program. It went into effect in 2006. So now seniors can get prescription drugs covered, either through Medicare Part D if they're in traditional Medicare, or through their managed care plan if they're Medicare Advantage. However, those prices are not set by the government. The government sets the price. When you go to the hospital, the government sets the price they'll pay for your surgery. When you go to the doctor, the government, if you're on Medicare, when you go to the doctor, so this is the regulated solution I'm talking about. When you go to the hospital on Medicare, the government sets that price. The doctor government sets that price. When you get a drug, the government does not. And that's been a source of great tension, which is why is the government not using its massive negotiating leverage to get lower prices. And for the first time, that has happened. In the Inflation Reduction Act, recently passed a couple of years ago, the government got the power to negotiate, effectively regulate, the prices of 10 drugs that were selected by the Center for Medicare and Medicaid Services. That list expands slowly over time. So it's a little bit, I mean, this is out of thousands of drugs. And the drugs had to have been on the market for more than 9 years, et cetera. So they didn't want to hurt the drug companies too much. So it's a very timid step forward, but it is a step forward, a major and important step forward. I was surprised to see it happen, but I was not surprised that if they were going to regulate any sector of healthcare, they'd come for the drugs first. Why is that? Because the drug companies, I think, when history is written, may have shot themselves in the foot with these ads. Nobody likes the drug company ads. I mean, those of us of my generation who raised our kids having to explain during football games why that guy in the Viagra ad kept throwing the football through the tire, and what that represented, are frustrated with it. I actually have a friend who's a pediatrician here in Lexington, Massachusetts. This is a true story. He had a 9-year-old come into his office and say, "I'd like to talk to you about Cialis." And my friend said, "What are you talking about?" He goes, "Yeah, I was watching TV and the ad said, talk to your doctor about Cialis." So I think we're all a little bit uptight. We're all a little angry with the drug companies. So it's not surprising that they went after them first, but it's been a pretty modest step, and we'll see where it goes.
We've also seen these may be outlier cases where patents are purchased and something that's simple, been on the market for a long time, insulin, the price, what do they do? Increase it 20-fold or 15-fold. So yeah, I mean, that's what breaks through in the news, right?
I mean, look, it breaks through the news, and look, there are very strong arguments against regulation. I was arguing with a politician just the other day who was saying, look, if the problem is, we need to enforce the laws we have. For example, patent law says that after 17 years, you should have to allow others to compete with you, but companies will figure out ways to extend their patent. They'll change a slight formulation. Or with insulin, a famous case where once invented, the patent was given away for $1, so everyone could benefit from it. But it's still hundreds of dollars because they innovated in the delivery system for the insulin. And so they keep that patent going for delivery system. In principle, we could address that directly. In practice, it's proven to be very, very hard.
Yeah. Turning to a question on a slightly different topic, but I think an important one. The question is about the concept of employer-provided insurance. For this audience member, it always seemed like an odd concept to them. why should our insurance be tied to our jobs? Aren't there lots of limitations because of that? Burdens on employers, limited options for employees. We used to study job lock, where you couldn't change your job or you'd lose your health insurance. We still study it. Where did this employer-sponsored idea come from? And is it a good thing? Is it a bad thing? And as you said, it's still the predominant form of coverage for most people. So, what's your thinking on that?
Yeah, I don't think there is a thoughtful health economist in the country who, if they were setting up the system, would have set it up as an employer basis. It doesn't really make a lot of sense for the reasons you listed, especially for small employers. I mean, they're busy trying to make ends meet. They can't afford a high-tech HR office. How are they supposed to figure out what health insurance options to give their employees? And as you said, it gets in the way of employees moving to the job that works best for them. Some employees sick in a job with health insurance might not want to move to another job because of fear of losing their health insurance. Obviously, the ACA exchanges help with that, but not perfectly. It exists largely because in World War II, we put on, it's a classic economics, political economy study, we put on wage and price controls. We told employers they couldn't compensate their employees more through wages, so they started giving them benefits. And the IRS then ruled that when you compensated employees through health insurance or through pensions, it was not taxable. Whereas you compensated them through wages, it was. So if MIT wants to give me $1,000 raise in wages, I'll take home after taxes, $500 or $600. If MIT wants to give me $1,000 of better health insurance, I get $1,000 of better health insurance. This is a terrible system. This tax break, by the way, costs the U.S. taxpayers $300 billion every single year. $300 billion. That's money that we could spend on so many needy things, but instead we give it subsidizing this inefficient way of getting people health insurance coverage through this tax break. So it's a system which shouldn't exist. It raises the question, which you might ask, since I was, there at the birth of the Affordable Care Act, we're working on it. Well, why not just get rid of employer-sponsored insurance then? And really, in some sense, here's how I think about it. Think about employer-sponsored insurance as a really fundamentally unstable building that's slowly crumbling. Indeed, in the years before the Affordable Care Act, employer-sponsored insurance with health insurance was falling at almost 1% a year. It was a slowly crumbling building. What do you do? Well, there's three options. One is you can tear down the building. You can say the building's decrepit, we're tearing it down. That's what single-payer advocates would do. The problem is politically, most people in America have employer insurance, and they're not super eager to give it up for something that they don't know is going to work. It's a very, very hard thing to get people to give up something for the unknown. So it's hard to tear down the building politically. The other is you can prop up the building. You can say, well, let's strengthen employer insurance. Well, that's just throwing good money after bad. Employer insurance doesn't make sense. Why would you strengthen it? We're already spending $300 billion a year for a tax subsidy. Why would we do more? So what the Affordable Care Act did is said, look, let's set up some netting around the building. So as it crumbles, we catch people and make sure they don't get hurt. Let's set up an alternative, which is the Affordable Care Act exchanges and expanded Medicaid. That way, we're not going to tell people they can't keep their employer insurance. We're not going to fight that political battle. But we'll make sure as employer-sponsored insurance slowly erodes, people have someplace else to go. I think that was a very good compromise. And I think it's going to continue to be, I think we're going to continue to see slow erosion of employer-sponsored insurance and more people moving to exchanges.
Yeah. So when somebody says, I don't want government in my healthcare, they're thinking of Medicare and Medicaid.
Well,
but you're telling me that there's a lot of government in my private health insurance too.
There is a huge amount of government in every aspect of your healthcare. Roughly speaking, the U.S. is an almost perfectly split 50-50 between private and public healthcare. About 50% of our healthcare spending is government, about 50% is private. We have a system where the government is involved in all aspects of healthcare. If people don't like that, that's fine, but they have to remember that there's consequences. So when people, for example, want to repeal the Affordable Care Act, as I said, there was a Republican president, Republican Congress. Their number one campaign issue had been repealing the Affordable Care Act. But then when they went to do it, we were told that 30 million people become uninsured, and people were like, wait a second, we don't want that. So, it's easy to say get the government out of healthcare, but the question is who's going to deal with the consequences?
Yeah, that was John McCain's famous thumbs
Yeah,
down
exactly.
on the Senate floor. Yeah, so let's talk about senior care or long-term care for a minute. So I'll quote another luminary in the health policy, health economics field, Jim Nickman, who said, for most forms of long-term care, we have universal coverage with the deductible of everything you own, which in some way rings true. So could you talk a little bit about the long-term care side of the healthcare industry, how we compare to other countries, what might be done to, especially as the population ages, to make this affordable and not impoverish families?
Yeah, actually, great question. As my hair is getting gray here, I'm working more on long-term care. It's something which has been really, I've turned to focusing on. I think it's really ripe for reform. Indeed, I wrote an editorial with some co-authors during the pandemic, highlighting that essentially we shut down the US economy and spent $3 trillion to save the lives of largely older people. And yet once the pandemic is over, we go back to putting the same crappy nursing homes and not taking care of them like we were before the pandemic. So the question is, why don't we care for the elderly outside of the pandemic the way we did during the pandemic? And the answer is we need to fundamentally rethink our long-term care system. What does that mean? That means a couple of things. First of all, it means most people want to get care at home, but we don't entitle them to care at home. We entitle them to nursing home care. Your point about it's universal coverage of the deductible, that's only for nursing home care. Home care in your home is not guaranteed. Some states provide it, some don't. So we need to universally guarantee that if people need care in their home, they should get it. That's what people want, and it's a better option than nursing home care. The second thing we need to do is we need to improve the standards of care we provide in nursing homes in America. It's outrageous, the standards, and we know how to fix it. And we do more to invest in that, in those. And the Biden administration has taken a step there with introducing some new standards to ensure there's reasonable staffing in nursing homes in the US, but we need to do more. But there's a third option, which grows. I've recently completed editing a volume. It's going to come out later this year on comparing long-term care systems around the world. We have chapters from 10 different countries, and we compare long-term care systems. And here's what's really striking that we're missing in the US, which is many elders can't really function at home, but aren't ready for a nursing home. We've solved that problem for the rich. It's called assisted living. Okay, if you're rich, we have this cool new thing in America called assisted living, which is basically older people dorms. You go, you get a room, there's a cafeteria, there's social events. My wife's ready to move in now. I mean, it's quite a nice life. The problem is it's only affordable if you're one of the wealthy, if you're a wealthy American. For 90% of the population, it's not affordable. We need to develop affordable congregate living options for the elderly who are lonely at home but don't need to be in nursing homes. We need to find a middle ground, and that's the really big place that we're missing in US public policy, I think, for long-term care.
Great. Thanks. So again, I'll repeat my call for questions. There's not a long queue of questions, so if you want to get your question in, this would be a good time to do it. I'm going to turn to another one, which is really about my word, not theirs, but I think it's implied, the sort of profiteering in healthcare, and sort of raising the ethical question of whether it's even proper to become a billionaire by investing in the suffering of others in a sense. Does that raise sort of opportunities for regulation or raising revenue, or is it just an ethical quandary that we have to live with?
I don't think it's an ethical quandary at all. I think that we should set the proper public policies. And if someone is smart enough to deliver a product that people want and make $1 billion, I see no ethical problem with that. The ethical problem is they're making the money off failed markets. You know, if you take someone who, there are actually more billionaires per capita in France than there are in the US. Okay, in France has highly regulated healthcare prices, a high tax system. Sometimes people just come up with really good ideas to make things people want, and they should be rewarded for it. So instead of focusing on the fact that there are billionaires, we should focus on what's broken about a system that's yielding some people billionaires, to be quite judgmental, who shouldn't be, for making money off a broken system. Let's fix the system that yields those sort of undeserving billionaires, if I can use such a judgmental term. But let's not focus on billionaires per se, because some are deserving. Let's focus on the aspects of the system, like broken healthcare markets, where certain providers dominate a system. Let's focus on that, and let's let the private sector innovate where they can. As I said, there's been miraculous benefits from private healthcare. So we mentioned private equity. Here's a great example of why this is a subtle issue. 2 recent studies. One study looked at what happens when private equity companies buy nursing homes. And what they found was nursing home quality goes down a lot. So that's a bad study. Another study I recently did looked at hospice. Well, there's been a massive growth, not necessarily in private equity, but in for-profit hospice. What we found is that expansion has been incredibly effective in delivering cost-saving hospice services around the country. We find that when hospice enters a market, it's massively cost-saving because people don't get wasteful end-of-life spending who don't want it. Remember, no one's forced into hospice, it's voluntary. But by offering this new voluntary option, by for-profit companies offer this new voluntary option, they're saving the system a lot of money. Now, they're making money along the way, but on net, they're delivering an option people want, and it's saving the government money. So if they make money along the way, that's okay. We just need to set up systems where we have the right incentives and the right rewards, and then let the economics work. And by the way, let me add one other thing. Right incentives, right rewards, and a proper tax system. Okay, we tax the wealthy way too little in this country. Okay, so the other thing is, rather than say an arbitrary thing like you can't make $1 billion, I hate hearing things like that. We should say, look, we need higher taxes. And then, like, as I said, there's plenty of billionaires in France, they have way higher taxes. Okay, we need a system where we're collecting the proper share from people who can afford it.
Great, thanks. So next question's about health insurance coverage for mental health services. So as you know, we've been sort of struggling with this as a nation for years, passing laws called mental health parity, which require equivalent coverage for mental health and physical health. This person's asking or suggesting that we haven't fixed that problem. And is there something that we can do to address, even as it appears that need for mental health services is rising post-pandemic and so on? Is there something we can do to improve health insurance coverage for mental health services?
Yeah, this is a great question. This is very personal because I was part of a big study called the Oregon Health Insurance Study, which was a randomized trial of health insurance. And we randomly gave people health insurance and looked at what happened. And what we found was over the short period of time we studied, it didn't improve their physical health. So the big headlines, health insurance doesn't improve health. It lowered the depression by 25%, which is the most astonishing result in mental health I think I've ever seen. Partly because people weren't stressed out anymore by not having health insurance. Okay, partly through better mental health care. And that got no coverage. People don't in America view mental health as health. And that's a mistake. Mental health is a fundamental aspect of health. And we need to boost our mental health provision and our mental health coverage. At the same time, we need to recognize resources for healthcare are not unlimited. If you give, basically in healthcare, there's a trade-off, which is you want the most generous coverage for the things people don't want except if they need it. There's no harm in having incredibly generous coverage for cancer because no one's going to pretend they have cancer. But in fact, mental health care is really vague. It's hard when you need it. It's hard to know when you need it. So we do need some controls to make sure mental health care has been delivered appropriately to those who need it. But we are way too far on that end right now. We need to move more towards the middle, where mental health care is treated more like the viable health care that it is.
Yeah, thank you. So I'm going to raise a related issue. We talked about really how much innovation in healthcare delivery and innovation generally has been driven by government innovation, investment in research, and also investment in payment systems and other kinds of arcane things that make healthcare tick. And really, the private sector often emulates Medicare in the way it pays for things. That's really where the innovation happens,
Right.
for the most part. But going back, this goes back quite a few years. The government felt it needed to change the way it paid doctors in Medicare. That Medicare physician fees were going up and uncontrolled, so they moved to a system of relative value units and prospective payment. We don't need to go into all the weeds on this. But essentially it said, we'll fix a price for Medicare doctor payments and we'll increase it for the hard stuff and we'll decrease it for the easy stuff. I'm oversimplifying. But at the same time, we've now institutionalized this sort of rank order of medical care. And then make it worse, we ask a committee convened by the AMA to adjust these weights. So I think there's pretty much a consensus, and you'll tell me if you feel differently, that we're way overpaying for certain procedural intensive stuff, Mohs surgery, where they're shaving skin growths and so on, is overcompensated. And things like counseling, cognitively intensive services that just take time, primary care, where they're coordinating, helping you coordinate your 7 complex medical conditions, are systematically undercompensated. So we get not enough providers in primary care, we get not enough providers in mental health services. Am I right that this is just a glitch in the system, that if we could fix it and have a more balanced payment system between the deep specialties and the more cognitively intensive, high-touch medical services, that would help improve the world a bit?
It's a great description. Look, I've been very glib in making it sound easy that we can regulate healthcare prices. It's not. It's very hard. I still think ultimately it's the right thing to do, but the case of the Medicare, what we call prospective payment system, illustrates the challenges. There's been a number of flaws with that system, and one thing that emerged as a flaw is that we overpay specialists and underpay primary care providers, and that's a big problem. If it feeds itself back into our shortage of primary care providers. If your kids wants to go to med school today, they got a choice. They can be a primary care doctor, make a good living, make $200,000 a year, work 60 hours a week and be on call every other weekend, or they can be a dermatologist, make $500,000 a year and work 35 hours a week and never be on call. I mean, what are they going to pick? We've got a real imbalance in how we compensate different aspects of healthcare that's been institutionalized through the regulatory system we have. So once again, I don't want to pretend that it's easy to set a proper regulatory system. It's been a challenge for Medicare.
Yep. Thanks. It's really, it boils down to a question of, which set of incentives gets you closer to the optimum, not what's perfect. I mean, I think that's a message that's coming through here. And I would observe that, every developed country in the world that has lower costs, and they all have lower costs per capita than we do, they cover higher shares of their population, and they tend to have better outcomes on average. They struggle with this every year too, and they're constantly reforming and rethinking. So there's nothing easy about this.
And let me jump in on one thing you said, Joel, because people might have noticed missing from anything in my comments was the word quality. And you pointed out, everybody points out, well, we have the highest spending and the worst outcomes. That is a very misleading statistic. I think it's important to note, because for people like you and me, Joel, we have great outcomes. Okay. Mm-hmm. If you look at a white baby born in America today, its chance of seeing its first birthday is pretty comparable to one born in Europe. If you look at a black baby, the chance of seeing its first birthday is lower than one born in Barbados. The problem in the US healthcare system with quality is not the average, it's the tails. The reason we have bad health outcomes is because that's driven by the excluded populations who are not integrated into our system. That's a problem of access, not a problem of quality. Healthcare quality, look, it can always be better, but it's plenty good for people who are in the system. It's just as bad for people who are out. Now, to be fair, it's as good as Europe and being 50% more expensive. So I'm not saying it's a good deal, but I think we have to be careful when we say our healthcare. People often say our healthcare, we're paying more for worse. That's not true. We're paying more for the same. which is
For
still
some
not great,
people.
but it's not as bad as it sounds.
Right, yeah. Point well taken, and we haven't even talked about inequities yet,
Yes.
except, that's an enormous problem in our system. But I'm gonna get to another question from the folks on the webinar. This person talks about government healthcare systems, including the VA. Without going all the way to a single payer system, is there an argument for maybe consolidating some of these large programs and allowing more people in, standardizing across programs and so on to sort of grow the strengths of the public system out to more people?
Yeah, it's hard. I mean, the VA obviously has a certain criteria that's hard to expand. Look, we haven't really, a natural question that comes up is a broader version of this, which is why not just have single payer? And I sort of touched on that a bit, which is that basically it's very hard to get Americans to give up something they have now for something they don't know. It's also hard to take on a $1 trillion private health insurance industry and win. So politically, I don't think the problem with single payer are not substantive. The problems are politically, it's just an incredibly hard battle. So anytime you want to expand public insurance, you have that battle. Now, the Affordable Care Act did massively expand public insurance, and we can continue to do that. I'm not sure the VA is the mechanism. I mean, in fact, the Medicaid system actually delivers in many cases very good health care. Medicare in many cases very good health care. I think we have existing public systems that we can continue to expand. I'm just not sure the VA is going to be a hard one, just because it's hard to know how you expand beyond the criteria they have.
Yeah. And in fact, sometimes they're stretched a little too thin, and they need to sort of reach out and bring in private healthcare resources to for some people. Well, I mean, that's a whole nother conversation that we don't need to have today. We have, let's see, about a little less than 10 minutes, if my clock is correct. So I'll put out one last call for questions. And if none, see if I missed any. I was waiting for the single payer question. Nobody asked it, but you've answered it anyway. I do a variety of panels like this, and I typically get that question, and it's like, what are the chances of us having Medicare for all? And I said, a snowball's chance in hell. And so I've gotten this reputation for being the snowball guy. But there were, I don't know, 4 or 5 states that had serious passes at single payer through referenda. And they all kind of go down in flames at the end, either because the numbers don't add up. You're shifting funds from employers to the tax system. That's very hard for states to do. Or vested interests, even those that we think of as pro government action, nurses unions, and so on, end up opposing it because they're worried about, what they have, what they might have would be worse than what they have. And I think that's the point you've made.
Yeah.
I think we live in a world of the healthcare world where incrementalism is the law of the land, and there's lots more incremental progress we could make. So I will just wrap with one last question, and that's sort of the elephant and the donkey in the room. And that is, we do have an election coming up. And I know it's very hard to make these kinds of predictions, but if it goes one way or the other, what do you think happens to our current healthcare situation?
I think that the Affordable Care Act is here to stay. I don't think there's a real risk. I think that there are actions you can take on the margin. Probably the most important is one of the most significant accomplishments of the Biden administration, the Inflation Reduction Act, was to make insurance much more affordable on the healthcare exchanges, to cap the amount of money people would have to pay for health insurance at 8% of their income. That law expires during the next administration. And I think if the Republican wins, I think that law will not be extended, and millions of people will see their health insurance costs go up, and that will cause possibly millions of them to become uninsured. So I think while the Affordable Care Act is here to stay, I think, basically the point is we're not going to see 20 million people lose health insurance, but we could see swings of several millions of people losing health insurance depending on how this insurance goes, how this election goes. So the stakes are real for millions of Americans. I think on healthcare costs, it's hard to say, to be honest. It's hard to say where there'd be more innovation. I think there's sort of equal taste and distaste for innovation on both sides of the aisle. I think that, I guess I tend to think that if the current Republican candidate were to win, we'd be sufficiently distracted with other things that we wouldn't be able to focus on the healthcare innovation we need. So I tend to think more healthcare innovation would happen if the Democrat won. But I think that's a harder call because both parties are sort of beholden to interests that are opposed to healthcare innovation. And I think that's going to be a tougher challenge. So I think all we know for sure is many more people will have health insurance coverage if the Democrats win than the Republicans win. And in terms of what happens to innovation, I think that's a tougher call.
Okay, thank you. So Jenny, are we, I think we're at time. Did you want to bring it home?
I'm back. This was a great conversation. I feel like we could keep going. And I feel like there are a lot of answers for which there are no answers, but there are a lot of really good questions. Thank you both so much for sharing your extensive knowledge with another informative Network for Responsible Public Policy discussion tonight. Our next NFRPP program will be Thursday, June 20th at 7:30 p.m. The topic will be a purple agenda for the next 4 years with Boston University professor Lawrence Kotlikoff and New York Times opinion writer Peter Coy. Please plan to join us. Watch your email for a brief survey on tonight's program. Your input helps us shape future programs. Thank you, and we'll see you on June 20th. Good night.